Thank you, Ajay, and thanks a lot for giving me this opportunity to discuss about the pathology of the neuroendocrine tumor. And a lot of some of the things were already covered by the previous speaker, and Sunil has made my life quite easy. So the spectrum of neuroendocrine tumor in lung cancer is quite broad, and we can see the tumors which has actually neuroendocrine morphology, which are described as entities of the lung, which include typical and atypical carcinoid, large cell neuroendocrine carcinoma, combined carcinoma, and small cell carcinoma, which can also occur with the combined with the other non-small cell carcinoma. But we can also see the neuroendocrine differentiation with the other common tumors like a non-small cell carcinoma, adenocarcinoma, or large cell carcinoma, and there are some rare tumors which can also shows the neuroendocrine expression. So the focus of this talk will be primarily to the tumors with the neuroendocrine morphology, or which are the entities of the lung. So what the clinician expect when we give a diagnosis of a neuroendocrine neoplasm. So the clinician expect that a precise diagnosis of neuroendocrine neoplasm, which is confirmed by immunohistochemistry. Ajay, can you see my slides, or because they are not moving ahead?
Yes, sir. Slides are.
Slides is visible, sir.
But they are not moving ahead. So let me stop share and reshare the slides. Okay, can you see it now?
Yes, sir.
But unfortunately, they are not moving ahead. Okay. So in a neuroendocrine neoplasm, we clinician expect a precise diagnosis, which is to be supported by immunohistochemistry, and there are parameters for grading of the tumors, which is based primarily on the mitotic count. Ki-67 has role of Ki-67 is not yet established, especially in the lung cancer. So to harmonize the various classification of neuroendocrine tumor, there was attempt was made. And in this, except for the lung, at most of the other sites, now the 3-tier systems of NET, grade 1, grade 2, and grade 3 is followed. And for neuroendocrine carcinomas, are the poorly differentiated neuroendocrine tumors, which are small cell and large cell. But still in the lung cancer, we still follow the categories which are typical and atypical carcinoid. So although there are some attempt were made as compared to the previous WHO classification to have a more close resemblance to the neuroendocrine tumors of other sites, but still the typical and atypical carcinoid categories are followed rather than grade 1 and grade 2. And the possible reason for this is that even the Sunil has also told that in lung cancer we get majority of the neuroendocrine tumors, they are poorly differentiated or high grade tumors, and the low grade tumors, they form a very small component. So that's why maybe the pulmonary pathologists, they still want to retain this. The classification, as I mentioned, is based on the morphological features, which is supported by the immunohistochemistry, and ISC is not a very established tool. The broad category of the differentiated tumors are typical and atypical, and these are the cutoff criteria which we use. The mitotic count of less than 2 per 2 millimeter square, lack of necrosis, and if the size is more than 5 millimeter, that is a typical carcinoid. But if the mitosis is 2 to 10, and if there is a presence of necrosis, it becomes atypical carcinoid. This is just to show the few of the pictures of the of carcinoid tumors, and there is a tumor which is occupying the whole of the bronchus, and there are various growth patterns which can be observed in the neuroendocrine tumors, which makes it diagnosis a little challenging, because although this crowd is not a pathologist, but you can see there are various histomorphological patterns or features can be observed, which can cause diagnostic dilemma, and even the differentiated tumor that, and it is a typical carcinoid, can metastasize to the lymph node and can show the local recurrence. This is the one thing which we have to pay attention, that is the presence of mitosis. If there are mitosis which are more than 2 per 2 mm square area, it becomes a atypical carcinoid. And the necrosis, this is the area which is the necrotic area. If it is especially the punctate type of necrosis which is seen into these are the criteria to call it as a atypical carcinoid. For the pathologist, we have to be very careful when we are evaluating the mitosis, because the pycnosis or pycnotic nuclei sometimes can be confused with the mitosis, and we have to be very careful in interpretation of that. So the characterization, the neuroendocrine expression for the neuroendocrine markers like a chromogranin, synaptophysin, INSM1, there are new markers also which it is required. And Ki67, as I mentioned earlier, also, although it is being done commonly, but it is not, it has established its role. And there is a problem with the Ki67 because sometimes it can show the heterogeneous expression, like the areas which I marked are very high in Ki67 as compared to others. So there it has a problem due to the hotspot areas, and there is inter-observer variability. So assessment is of Ki67 is problematic. Just in brief about the large cell neuroendocrine, as the name suggests, if the cell's morphology is large, it should be more than three times the size of the normal lymphoid cells, and they closely resembles the non-small cell carcinoma. Like they can morphologically look like a adenocarcinoma or squamous carcinoma, but it has a neuroendocrine morphology as illustrated in these pictures. And you can see the nested patterns or neuroendocrine morphology. And if you confirm it by the immunohistochemistry, and if the MIB1, if it is large cell neuroendocrine carcinoma, it is usually more than 30%. And you can get many large bizarre cells. So large cell neuroendocrine carcinoma, we have to keep these possibilities in a differential diagnosis, because the same morphological features can be seen in other type of the tumor. So to label a tumor as a large cell neuroendocrine carcinoma, we should do IS immunohistochemistry for neuroendocrine markers only and only when on morphology you are suspicious of neuroendocrine morphology. If you put randomly these markers on any other tumors, you can fall into the trap of calling adeno or squamous carcinoma being a large cell neuroendocrine carcinoma. The last category, which is the small cell carcinoma, as you can see in these pictures, they are the cytoplasm is very scanty. They are placed back to back, and which cause the molding. And these tumors, when we see such tumors, the differentials which we have to keep in mind is about the other round cell tumors, especially the lymphomas need to be excluded. And they are for characterization, the expression of neuroendocrine markers helps to confirm the diagnosis. Another category of these tumors is the combined carcinomas. When you see both non-small cell carcinoma and small cell or large cell carcinoma component, they are called as a small large cell combined carcinomas. But we have to keep in mind about the small cell transformation, especially if the patient is a known case of EGFR mutated adenocarcinoma, and it is showing the small cell carcinoma component. That can be the possible reason for the resistance or the progression of the disease. Now the problem in the diagnosis, one and most problem which we face in the routinely, that the expression of these markers is usually variable, and you can't rely on one marker. Especially the diagnosis can be challenging on the biopsy. This is the summary of the diagnostic, 4 diagnostic categories which are on histopath. But from the treatment point of view, the 3 tier system, that is a typical and atypical carcinoma, they come the low grade neuroendocrine, typical carcinoma in the low grade neuroendocrine tumors, and atypical in the intermediate grade, and small cell and large cell in the high grade. So clinically there are 3 tier systems, but from the pathology side there are 4 tier systems. So when we deal with these these tumors on the routine diagnosis, these are the common problems which we face. The important one is to distinguish between the typical and atypical carcinoid, for which the morphological features we have to take care of that. Another point is about the grading of these tumors and the utility of the Ki-67. Is it really reliable or not? I'll just quickly touch up on a few of the points. And there's a few new entities which are mentioned in the WHO. One diagnostic category is put as a carcinoid NOS. So this is also like similar to the non-small cell carcinoma NOS. So if you are not able to distinguish between the typical and atypical carcinoid, especially in these three situations, then we can use the diagnostic category as carcinoid NOS. Few recommendations are also for the pathologist when we evaluate the mitosis and necrosis. We have to be very careful. And now the recommendations are not to use the 10 high power field because the field diameter of the microscopes varies. So this is the chart which is should be pathologist should kept handy with them, and depending on the number of the field diameter of the microscope they are using, they should calculate the mitosis. And for mitosis also, we should try to look for the hotspot areas which are showing the viable tumors. And if your counts are close to the cutoffs, like if it is around 2 or the more than or around 10, then in those situations we have to count additional fields. The role of Ki-67 as a diagnostic marker for grading of tumor and for the therapeutic treatment decision, it is still not established in the lung, but it might have some prognostic role. And there are no definite criteria, especially in the lung, as compared to the GI and other sites for the neuroendocrine tumors of the lung. But it can be of very of help to us, especially if we get a very small tiny biopsies, and like shown in this example. So you can't, based on morphology, you can't make out. So in this case, there is a Ki-67 is very low, but the other side it is showing a high Ki-67. So the similar morphology can be so based on the Ki-67 you can pinpoint that this is a small cell or typical carcinoid. Role of Ki-67 cutoff, as I mentioned, they are not very precise, but if it is more than 5%, then you are likely to deal with the atypical carcinoid, and if it is more than 30%, then you are likely to deal with the high grade neuroendocrine tumors, either large cell neuroendocrine carcinoma or small cell carcinoma. So the counting of Ki-67, there are some recommendations also, and now it is being era of digital path or AI. So now there are new tools also which helps to quantify the Ki-67. There is another new entity which is described in the neuroendocrine tumors is the carcinoid tumor with the elevated mitosis, total counts, or Ki-67. So this is equivalent to the NET grade 3 neuroendocrine tumor grade 3 of GI tract, which shows high mitosis. And so in these tumors are also were of debate whether to call them as a large cell neuroendocrine carcinoma or still or NET grade 3 as we call them in GI tract, but still they were put as this distinct entity because the molecular profile of these tumors resemble more than like that of a carcinoid tumor. So we have if you see such cases, we put a rider that this is the tumor with increased mitotic or proliferation activity. And last, to touch up a little bit about the molecular classification, that is also evolving, and not only in the in all the categories of neuroendocrine tumors. And so typical carcinoids are molecularly now categorized into the 3 subtypes. Depending on the molecular profile, but it is not very commonly used in the clinical practice. And similarly, the large cell neuroendocrine carcinomas, it is proposed that they are composed of 2 distinct phenotypes, the one which is more resembling like a small cell carcinoma, and another which resembles like a non-small cell carcinoma. And there is the difference in the molecular alterations which we get in these 2 subgroups. And finally, about the molecular profile of the small cell lung cancer, it is gaining a lot of interest. And now it is being proposed that small cell lung cancers can be of 4 subgroup because some subsets of the neuron small cell carcinoma, they don't express the neuroendocrine. So based on the neuroendocrine marker expression, whether it is expressing neuroendocrine markers or not expressing neuroendocrine markers, they are categorized into the 4 subgroup like ACL1 and NeuroD. These subgroup, they show high expression of neuroendocrine markers, but POWD and YAP1, they show the low expression of it. So, and even for these, now the immunohistochemistry markers are also available. So now in future we will see further categories of small cell cancers, and there are a lot of trials which Sunil talked about. So they can show the differential expression in those cases. So this classification of the molecular classification of small cell carcinoma will be of interest and might come into the clinical practice very short. So to summarize, these are the broad categories of the neuroendocrine tumors, and till date we follow the carcinoid tumor, carcinoid and atypical carcinoid. The grade can be added, but it is not mandatory. The molecular classification of neuroendocrine tumor is evolving, and as I mentioned, that we might get of these 4 subgroups of neuroendocrine tumors based on the molecular profiling in future. So the neuroendocrine tumors are defined as the zebras of oncology because they can show a lot of variability or heterogeneity both in the morphology as well as the clinical profile. With this, I end my talk, and if there are any questions, I will be happy to take them.